ಯಾರು ಕೊಟ್ಟು
ಅವ್ರ ಲ್ಯಾಪ್ಟಾಪ್
ಈ ಕೇಬಲ್ ಆಯ್ತಲ್ಲ.
Thank you so much. Nice meeting you. I listened to your talk, B-scan and first in Arvind Tirunelveli. It was very nice. Nice meeting you in person. My regards to Dr. Patil.
If you guys are still awake, we'll have an interesting session. Right? Anyone wants to pick coffee? There are some paper cups on the side. You can actually fill and come back. Any water break, anything? Should we start? Or okay. So this is a practical session. That's the thing. So as long as we have time, I think so we can make it interactive. And I would invite Dr. Savita Arun. She's the chairperson for the session. She's medical superintendent and director at Netradhama Eye Hospital. She's passionate about quality. She's an NABH assessor, and I've known her to be driving quality initiative at Netradhama for many, many years. And I'm Dr. Gagan. I'm an oculoplasty surgeon. So we are ophthalmologists. So, we will be having our talks more towards the clinical side. And we do have Venkatraman and Mr. Shailesh who are representing the other side. So, when we are having talk, probably we'll try to bring that practical angle where we all have issues, right? So our first talk is by Venkatramanna. Venkatramanna heads the labs at NN, and he's been a pioneer in introducing many services in Bangalore, starting from 2006 when he joined Narayan Netralaya. And to give a perspective, he is very practical. So if I have end-off or cluster end-off, there are few phone numbers which are in like that list whom I'm going to dial. His is one of those numbers. So, you have end of anything, he knows what to do, where to do, very practical, and he has been behind the scene working for various hospitals and various, end of cases and cluster where he has investigated, and he also helps in maintenance of OT protocols and everything. So he has lots of practical knowledge. If you have some personal questions also, you can catch hold of him afterwards. I believe he'll answer that. And our lab services under him are excellent. So even with our oculoplasty and other cases, he has helped us a lot with our infective case and other things. So I invite him for his talk, and I hope it will be really, really useful to us.
So, good evening, everyone. At the outset, I would like to thank BOS for giving me opportunity to give me my talk on microbial surveillance of ophthalmic operation theaters and approach in diagnosis of endophthalmitis. So, as a ophthalmic setup, is it necessary to do microsurveillance? We get a lot of questions. The first question is microsurveillance is necessary? If so, when should it be done? And how far we should be done? How to interpret the lab results, and what will be the implication in terms of continuing the theatre in case of adverse results. I'll answer all these questions in my coming slides. When the microsurveillance done is, it is done during routine surveillance monthly in designated OT areas, and when new hospital is constructed. Once hospital is constructed, after all the validation is done of the HEPA filters and AS and the different protocols, we need to check the microsurveillance in all the OTs. All three cultures should be negative. Then only should go for commission of the OT. It's very, very important for a new hospital construction. And when there has been an outbreak of endophthalmitis, either it is sporadic or cluster infections. And surveillance is divided into two. One is routine surveillance, and in case of emergency or outbreaks. We need to check the quality of air, water, consumables using in the OT, and surface swabs in the OT to check the effectiveness of your disinfectant used and how the cleaning protocols is in place. To check the air, whether it is what is plenum air conditioning or laminar flow or wall mounted, first you need to check the air quality using either a settle plate or air sampling. So the settle plate should keep that covers the entire area of the OT. That should be entry of the OT, both corners, and backside of the OT, that's both corners and center. Or you can do, if you have facility of air sampling, you can do for air sampling by measuring the area of the size of the OT. Once you've done the air sampling settle plate, there is some criteria of the microbial load. In empty theatre, it should be the colony count should be less than or equal to 35 coliforms per meter cube, and during operation should be less than or equal to 180 CFU per meter cube. In ultra clean laminar filter theatres, it should be 20 CFU at the periphery and 10 CFU at the center. Apart from surveillance of OT, you need to check the parameters to be tested for air conditioners. First is temperature humidity check daily, air particle count once in 6 months, air changes rate calculation once in 6 months, air velocity at outlet of terminal filtration unit once in 6 months, pressure differential levels of the OT with respect to ambient adjoining areas. It should be in once in 6 months. Validation of HEPA filters and integrity, it is once in 6 months. We need to check the quality of water for microcontamination. It should be once in 6 months. And irrigation solutions every batch, and viscoelastic solutions every new batch, and surface swabs of theatre once in a month. Again, to check the effectiveness of disinfectant and process of your cleaning protocols. When you take surface swabs in the OT, all the floors, walls, table, microscope, trolley, fecal machines, any pendants, anything like that, and sent for culture. The permissible count is should be less than 50 coliform units per ml. So water is very important. We need to collect this water from the scrub area as well as wherever the stores the water for RO water in the supplies to the OT. To check the any coliform bacteria, important, or any other bacteria. If it is 0 is high satisfactory, if it is 1 to 2 satisfactory, and 3 to 10 is suspicious, then we'll go for cleaning of the tank. Usually what we should do is, should clean the RO tank monthly once using superchlorination, or you can with sodium hypochlorite. That removes the biofilm of the pipes. Suppose if there are any unfavorable reports, what to do? There is no panic, and no need to stop the operation theatres. Repeat the cleaning and fogging if needed. Check the air conditioning filters and repeat the microbial culture. Check the microbial reports and discuss with the HSC committee. Apart from this, we need to check the efficiency of autoclave and autoclave. Should use the bulk indicators and check the whether it is autoclave is functioning properly and it is functioning properly. Along with the bulk indicators, it should send on control. Now I'll talk about what is the approach in diagnosis the endophthalmitis. So endophthalmitis factors are multifactorial, whether it's from patient or from prophylaxis, the surgical procedure, or IOL metals used, and chelation and aseptic techniques. So again, endoph is either sporadic or custom infection. The common cause of custom infection is intraocular lens, trypan blue that is used to stain the capsule, irrigating solutions, local anesthetic drop, and viscoelastic solutions. The common causes of post-op endophthalmitis are, first one is external flora, that is Coelius negative staph aureus, staph epidermidis, and strep pneumonia. This happens when the dissemination happening of the eye before surgery, and the contact is less. Then this is the common cause of endophthalmitis. In failure of sterilization, Pseudomonas species, any contaminated with surgical instruments, irrigating solutions contaminated with microbial or fungal things, and OT environment is contaminated with fungal. When there is seepage or water leakage in the OT, the chance of forming the fungal infections. And pre-sterilized IOLs, viscoelastics, fungus and Pseudomonas is the common culprits. How to go about lab diagnosis? Whenever you want to encounter the endophthalmitis, you send for gram stain, KOH, bacterial culture, fungal culture, and PCR. Why I am referring to PCR is, if the amount of bacteria or fungus is very minimal in the sample, you can't see in the gram stain and culture. then best thing is to do the PCR. Even small amount of bacteria you can fix in the PCR. And one more thing is, here we are doing the nested PCR so that we are amplifying the 2 rounds of genes. So even if one small bacteria is there, we can amplify multiple times in first round. Second round, we have to pick the what opportunities. And one more thing is, sometimes what will happen is, if patient under prior antibiotic therapy, then you can't see in the gram stain and culture. So the only thing you can see in PCR. And one more thing is, if you see propionate acne, it causes delayed and end off. In that case, again, difficult to culture the P. acne. Again, you need to do the PCR, so it is more accurate and more specific. This is the diet smear of aqueous and vitreous taps. You can see number of polymorphs, and you can see gram-negative bacteria. It's the end of patients. And again, one of the patients with number of polymorphs with gram-positive cocci. This is one of the patients with fungal filaments in the aqueous and vitreous taps. So you can see growth in the blood agar and the BHIB. As soon as we'll get the sample, we'll put the sample in the BHIB or liquid media, and we'll do in culture in solid media. You can see the metal growth here. Then remaining sample, what we'll do is we'll take the sample and extract the DNA from the sample, and we'll amplify the specific genes with primers for U bacteria, panfungal, and P. acne, and we'll see on gel documentation. If you see here, U bacteria, clearly you can see the positivity here, both first round and second round, along with control. If you see no growth no positivity in the negative control. Again, this is one of the P. acne gel. So you can find, see, P. acne is unrobed. It takes long time to grow. So then dilemma happens. So what my suggestion is, whenever end of year happens, then send for all this process. Then you can't miss any organism. You get exact diagnosis, and you can have better treatment. Thank you.
Thank you, Doctor, for that excellent, comprehensive and exhaustive message on talk on microbiological surveillance and approach to end off. I have 2 questions for you. What's your recommendation for cleaning OT tables?
Okay.
And the second one is a sporadic case of end off in a busy OT practice and high volume OT. Do you recommend closure of the OT? What is your
yes,
take on
sporadic, you shouldn't find how many cases occurred on a particular day. One patient means, then no need to worry. If it is no need to worry, check the patient status and check the batch of autoclave what are using for that, and other solutions what are using for surgery, and do the routine analysis and find the root cause first of all. Then if root cause is come from the OT, then close the OT, then do all the what are they called indicators, everything to check. Then go once everything is perfect, then go ahead with surgeries.
No, my question is, if it's a sporadic case, we'll be finding out the next day. By then, OT will have started. So the practical issue that
then what should do is you should clean the product, clean the OT, then go ahead with the.
It's already started.
Okay.
They come about 20, 48
Pardon.
hours.
Recording this? Okay, then I should keep short. Recording, otherwise I would have said something. Okay. Then we have to be
Generally what
politically
happens,
correct.
today I have operated one case. So patient is fine. Today we have operated one case. Patient is fine. OT is going on as
Yeah,
usual.
yeah, yeah.
3 days later he comes with infection. And our OT is continuously going on.
Okay.
For such cases what we do? Because already the it takes practically
You can't close the.
Stop recording for 1 minute. 1 minute stop, then you start again. Okay. Stop. Raman, I'll confound the matters further. Even if it's one case and that, stop now? Okay. If it's one case and that patient somehow makes a complaint, goes somewhere, whatever, and that goes to the government agency. It has happened, and it's not in Karnataka. The first thing the DHO questions is, did you close your OT after that case, if it goes? So, practically what you're saying is true. What the other aspect is that, they are not bothered about sporadic and all. The first question coming from government authorities is, you had end off, did you close OT? So, That's why I told to stop the recording. Now you can discuss on that, but this is what the reality is.
Reality is
That is what the truth is. But
So usually we won't close the OT. Is my hospital, we won't close the OT. We'll analyze the what happened, this thing. Mostly we found that from patient factors.
patient factor.
Yeah, mostly from,
Okay,
from patient
fine.
factors.
Yes. And my second
Yeah.
question is,
Yeah, what are we using? We should use a high-level disinfectant for cleaning the OT tables. High-level disinfectant is fine.
So bacillus and bacillus.
No, bacillus. High-level disinfectant can use. No, can use many are there. Like H2O2 is there. Yeah, Vircon is there. Vircon is there.
Yeah, we can take that.
Yeah,
they will not corrode your steel OTs.
yeah.
okay.
That's the problem.
We have Vircon is there. Vircon is fine.
And
Bangalore OTs are steel OTs now.
standard recommendations for cleaning infected instruments in ophthalmic OT, like say when we do a DCR or a therapeutic PK or an end of thermite disinfectant. So what would be standard protocol for?
DCR is not considered to be infected.
Yeah, no. If it's a, say, infected,
Yeah.
yeah, other than that.
DCR is a routine processing everywhere in the world,
Okay.
except for few places in India. No, I'll say truth, madam. That's why recording is there. But yes, other infective instruments.
So we have separate disinfector. We have a disinfector is there only for infected cases. So no need of touching with manually. So everything will keep it inside that one. Then automatically cleans and will go for send for autoclave.
Like, I think a lot of people are using sodium hypochlorite.
Again, it is corrosive, no? If you use corrosive.
So there's the other option of betadine. Is betadine recommended? That's all. I just wanted to know because some places are using betadine.
No.
Because sodium hypochlorite is known to corrode.
Yeah, corrosive, yes.
Life of instruments.
It's be
Only after COVID, everyone has realized what has happened to furniture and OTs.
Furniture, exactly.
During COVID, it was overdose of hypochlorite. Then everything it is an overdose of.
okay.
Yeah, thank you so much. I call upon the next speaker, Dr. Meena Menon from Shankara Eye Hospital, and she'll be speaking on cleaning of the OT, a video-based discussion. Welcome.
Here, I will have to connect my laptop.
Your name?
Dr. Meena. First, you have to open that and then open this first.
I think they record all the dogs. All the dogs of BOS and KOS are recorded.
What has happened is it has come to bite us. She can, some of our talks in AIS and all there on YouTube, they have been sometimes empty closure. So that I wouldn't have.
So the videos, because of the videos, it is taking so
I
long.
don't know. Maybe.
You want me to get my laptop?
I think there is a large file.
Yeah, lot of all it, talk itself is video based. So. So they go that and they post it.
Not only that, WhatsApp messages have been quoted. So what happens? There are a lot of they are all WhatsApp on sequence. Not if you take only one. The earlier and the later.
Earlier will not come.
That's why I'm not kind of posting anything on WhatsApp after this was there.
Thank you, BOS, for giving me this opportunity. Actually, this is a collective effort from Team Shankara. So, why is OT cleaning essential? Definitely, it's as a part of daily routine to make sure that our patients and staff members are kept safe.
Cleaning the OT and its immediate environment, it minimizes the patients and healthcare workers' exposure to potentially infectious microorganisms. When do we clean? Now, whenever we are preparing a new theatre, every day before we start the surgeries, in between the patients, and definitely the terminal cleaning, that is after the last surgery of the day, and weekly or monthly deep cleanings. Where to clean? Yes, all areas which is unrestricted, semi-restricted and restricted areas within and immediate environment of the OT have to be cleaned. Now always the start in the operation theatre before moving to the scrub areas, anesthetic, block, recovery and then the sterilizing area, dirty corridor and the toilet should be cleaned last. As you all know, it's very common. What are the tools which are required? Usually mops and buckets, rubber pushers, appropriate disinfectant. There are n number of disinfectants. We have to choose accordingly which surfaces we are cleaning. Absorbent and lint-free clothes and measuring cups. So before starting to clean the OT, these are our support staff. You have to wear rubber gloves, not the OT discarded gloves, rubber gloves and shoe cover, and they protect themselves with a apron as well, so that unnecessary spills don't get into their body or eyes. So once at the end of the OT, get the trash out. Now this is a biomedical waste management as per the Pollution Control Board. This is a Karnataka color guidelines which we follow. So once the OT the last case is over, first thing is to get the trash out. As we were discussing, there are a lot of cleaning and disinfective materials which can be used in healthcare settings. There have been a recent kind of quartz were the common ones which were used, quaternary ammonium compounds. But I think the recent guidelines, they are more towards chlorine compounds. The NABH guidelines says more towards chlorine compounds. So whatever it is, whatever disinfectant you are using, the most important thing is measure. Never adjust Madi, always measure as per the manufacturer's instructions or guidelines. It's mandatory to have a measuring cup in the OT and train the support staff accordingly. So the same way, the water also have to be measured, then only the dilution of disinfectant become very appropriate. So the water also have to be measured as well as the disinfectant also has to be measured. Now, mopping, yes, make sure that we don't miss out on spots. So if you see in this video, the bucket is kept and the mop is done only till here. So always empty the corridor or this blank spaces and make sure that no spots are missed while cleaning the floor. And there is a technique called as figure of 8 mopping technique which should be done. You can see it's a figure of 8 mopping. This is just to show the technique, and always the back is away from the cleaned area. So you are going from the cleaned to the uncleaned area. And currently we are following the 3 bucket system. That is, we use a detergent and a water solution in the first bucket. Then there is a then there is a plain water to remove the residual detergent, and then you have a disinfectant solution. So this is called as 3 bucket system of cleaning the OT. Now there has been advocacy of 2 bucket system wherein you use a warm water and a disinfectant also. So this is the one which I said, 2 bucket system is currently advocated, wherein the first is a plain water which is to be warm water, and the second the disinfectant. Again, in the bucket and the measuring cup, it should be there with appropriate markings. So before the surgery, all the flat surfaces, it should be wiped from top to bottom and then from the center outwards. The patient's bed, its attachments, whatever positioning devices which we are using, and the patient transfer devices like the wheelchair, trolleys, all these things have to be cleaned before the starting of the surgery. Finally, clean and disinfect the floor as well. So this is one thing. Please don't use a broom in the OT. It gets agitated, the dust gets agitated, which spreads it. Always use a dust mop. So in between the cases also, it's better to clean the OT. So usually the soiled areas of the floor, the furniture or the equipment that comes in contact with the patient or may have become soiled or damp. Many a time the drape, through the drape, the water seeps to the head end of the patient. And of course the blood pressure cuffs which is used in the anesthesia, I mean daily, each patient will be attaching a pulse oximeter. All these things have to be wiped after each patient. And again the floor around the operating table, that is considered as around 1 to 1.5 meters around the head end, also need to be cleaned. Now this is a spray, aerodazine spray, no financial interest. So this is what we generally use to clean the bed as well as the chairs and the surrounding head end of the patient. End of the day, again wipe down all the surfaces including the tops of operating tables and all the furniture, switch the equipment off at the vanes, and do not clean the microscopes or lenses using soapy water. Clean the anesthesia machines and then last clean the floor. Then there is this weekly deep cleaning wherein we remove all the articles from the OT and shelves and clean all the surfaces thoroughly. Now you can see she's cleaning from top to bottom. So all the entire OT is emptied and then the cleaning starts. And of course the cleaning will include your air handling unit and the pre-filters as well. Now, regarding the equipment cleaning, do not clean the microscopes or lenses with soapy water. They use a cloth damped with 70% alcohol or disinfectant as per the manufacturer's instructions, including the handles. So, this is a lint-free cloth which we use to clean the lenses. This is the AHU cleaning. As I mentioned, AHU, this is the inside part of the AHU which is being cleaned for the dirt and the muck. And this is the pre-filters which is being washed and cleaned. So usually the pre-filters and the AHU area only can be cleaned. HEPA filters should never be removed by the hospital staff. Usually it is the inside filters are cleaned by the manufacturer. Okay, suppose this is not an uncommon situation wherein the patient vomits or some kind of a spill happens. Now, I mean, this is a representative spill. I didn't want to show a vomit. So that's the usual thing in case if the patient, it can happen. So how do we handle them? So we have to use a freshly prepared hypochlorite solution, 1% hypochlorite solution. Place the caution board for as soon as the spill happens. And what you can see on the left hand side, they are pouring a very small amount of hypochlorite solution. No, it should be poured over and around the spill area. Enough hypochlorite solution has to be used. That is 1% freshly prepared hypochlorite solution. Then use an absorbent tissue paper to absorb the spill. Once the spill is completely taken by the absorbent tissue paper, then mop with the disinfectant. Now the usual question happens after this, can you start the OT or do you shut down the OT? Never shut down the OT. After 20 minutes or half an hour of disinfectant exposure, you can restart the OT. Now, once we do, these are some of the protocols which we follow. It need to be displayed to all the stakeholders. And again, these documents are always dynamic. We have to keep changing. We have to keep periodically review these charts, read journals as per the latest guidelines. We may have to modify these things. We understand from other institute, other organizations, and of course training should happen as on a continuous manner, because the support staff, there might be a change in the support staff or other nursing staff in the OT. So continuous training is essential. Thank you.
Thank you. Thank you, Dr. Meena. That was very good and useful video-based presentation. Now I call upon Dr. Gagan to talk on ideal OT layout.
Any questions from the audience? Otherwise, everyone will sleep. These are boring topics at times.
Actually, these are very useful even for private practitioners.
Madam, the first time I got any batch book in hand, I used to sleep reading 1 page or 2 pages of that. So it's if we have some personal interest, probably yes, but. No? Hmm? Let's check. So my talk is on OT design. So the first slide has a figure of heart and it says ideal OT design. So heart, because I think so all of us are more passionate about our OT than anything else. Heart and soul of ophthalmology, I can speak of that, is our OT. And the talk title I was not happy about, but I didn't ask to change. Because the first thing is when we say ideal OT design or something, what is ideal? If you know a parameter, you can measure and then you can benchmark. There is nothing in India at least which you can call an ideal. Reason being, health being a state subject and as well as being a national subject, you have plethora of guidelines. People say health is not regulated, doctors and hospitals do what they want. In fact, it's an over-regulated sector where you have so many guidelines and legislation and you really don't know which one to follow. Right. So, I would say that you have to live with state authorities, and I travel across India, Dr. Savita does, I have been almost to every corner. I think so there is a very distinct bias in practices statewide. And if I am in Karnataka, I would obviously need to follow that because you have to survive here. I'll do. Sorry. So, I don't know why it's coming this way. It's okay. Can you bear with this? Okay. So, I think so lots of things and practices are based on the city and state you are, because that's where you are registered, and that makes it totally different. So, I really don't know ideal. I can tell you the good principles. I can give you the references which you can read and make your analysis, and that is the crux of this talk. So some of the broad principles when you are designing OT are zoning. Now zoning in a single OT for ophthalmology is very difficult. So you may not get perfect zoning if it's a single OT setup. In that case, you need to have a unidirectional flow. So the material, patient, staff all have to go in a unidirectional manner. So now if we are talking about unidirectional manner, you may need to have a separate entry and exit. Courtesy, some guidelines in 80s and some of the OTs constructed in India in 80s and 90s, all ophthalmic OTs have one entry. So if the OTs have one entry, the fact that you want to have a unidirectional flow, go for a toss. Okay. And it's all across ophthalmic OTs, and let us not name because of this recording business, otherwise I would have reeled off the name list also. And the contrasting picture is, this is a problem only in ophthalmology. This kind of talk, we talk in ophthalmology. You don't get, if I go to a non-ophthalmic conference, I don't talk about OT designing. Their OTs are actually following the designs which are there. So if you are constructing a new OT, you want to learn about OT, please don't look at ophthalmic hospital. All of us are in the same state. Look at any hospital which is non-ophthalmic in nature. Many of the discussion and question which you ask will be answered on your own. Okay. And similarly, then the size comes. With the size, air conditioning comes. And I have come across many OT designs when I have consulted to all the people. The OT size and the air conditioning don't match. Then they are not able to get temperature and humidity control. Right. So ultimately, someone dumps something onto you and we buy paying lakhs and lakhs. But we have to be aware that your air conditioning will get affected by the size. Check what is required in your area, and in coastal areas, it might be a little different also. What is your equipment planning? And I'll come to one slide where you get answer to that. What is the material which you are going to use OT? What you are calling modular OT is not modular at all. You are being sold normal OTs by saying modular and being charged more. CSSG. You have seen ophthalmic OTs with very, very small CSSG. Something fits in there, but the moment your load increases, moment new machines come in, you really can't function in that small space. And you can't increase that. And civil work in OT is a pain. If you have ever thought about it, you will agree that you will ultimately say, leave it as it is, I'm not going to touch it. Where are you going to store your consumable? Where are you going to store your sterile supplies? DBCS guidelines, medical college guidelines are different. And medical colleges still have a different set of guidelines. So you are not storing material at times, or what kind of autoclaves you are using. Then linen, biomedical waste, madam touched upon, again something. And medical gas supply, again a requirement for your OT, how are you going to get gases in? Are you going to use cylinders, you are putting pipeline? And what is your power supply? If you have read about the recent fires in the hospital, the Delhi fire, the issue was oxygen cylinders, the pediatric hospital, where they, cylinders burst and that was storing oxygen and doing whatever it was. No one knows the truth, but oxygen cylinder was the really one which flared that fire. And the second fire in an ophthalmic hospital in Delhi, which all of us have seen on WhatsApp, is electrical overload. So where do you get all this information? All guidelines which are given by government, armed forces, railways hospital, central hospital, everything is from National Building Code. National Building Code was last in 2016. You can download that book. It's available multiple places. You can read, architect, everything derives from this. Now, deriving from National Building Code, you have Clinical Establishment Act guidelines, which are virtually across half the India. KPME is predating CEA. So some of the part is there, some of them is not there. But what is rumored is always that whenever KPME gets modified, it will go in direction with CEA. So I am assuming that sometime, it was supposed to be earlier, but in near future, KPME also gets aligned to CEA. Then before CA, you have Indian Public Health System guidelines, IPHS guidelines. Ophthalmology come into 30 to 100 bedded hospital setup. There are no daycare guidelines per se in most of the India, with some footnote somewhere. Then recently, Ministry of Health and Family Welfare have given OT operational guidelines. Okay, and they have also come out with CSSG guidelines. Now these two guidelines, in fact, are exactly same what you have got in NABH guidelines. And NABH guidelines are, so these two are actually summation of whatever you want. And since these are central, they are being actually used everywhere now. So these are the two documents you can download, and you can get whatever I'm going to talk and whatever this session crux is. And I think so being the current, that's the information which is relevant. Then you have NABH guidelines on OT air conditioning for accreditation, but the same guidelines have been copied in other standards also with a little change of word. What they mentioned is that split ACs are not desirable as they are recirculation device. Okay, so the debate about split ACs and HEPA filter, before we have, please refer and you will get your answer. There are multiple state, central, DBCS, AIUS, there are multiple guidelines. I have a full folder of guidelines, but I think so a guideline which was given by 20, 30 years old is no use now. You have to go with the current guidelines. That's my take on that after discussion with people I know. So these are how standards are, and then we have this Indian standard, BIS. Some of them apply to hospital, and IPHS standards will be there. So you can, if you really want, refer to these documents, which is the job of an architect, but I really don't know, we have hospital-specific architects, at least for ophthalmology, I have not come across someone. They do their business and there are more things. And what you get is, this is the thing, I can only make and give you this. Problem is when we start small, and getting an OT with a single person practice is a big, big challenge. So at least see what we can do. There are always compromises to be made. So hospital classification has been changed in NBC. Corridors have to be 7.8 feet, and we saw that in the video presentation. The door width is 2 meters, and we saw 2 meter door. Not many hospitals have 2 meter door. 2 meter is almost 6 feet door, right? There are like 3.5, 4 feet also when you come out. Why 2 feet? There's a rational bit of this 2 meter. It's for all hospitals. That's for the movement of the stretcher, along with the people around. So 2 meter doors are required for any hospital door across specialty. Ophthalmology doesn't have a separate requirement. Ophthalmology doesn't have separate structure. Staircase width, anywhere fire 2 meter is standard. Fire exit door, standard. These things are standard across. There is nothing special which you can do in an ophthalmic setup or ophthalmic OT. And HVAC system, heating, ventilation, air conditioning, in simple words, air conditioning, what we talk, is mandatory, and that adds to the safety and infection control. Whatever split system we are able to use, probably even I have used, I'm still using sometimes. I really don't know how long that will last with the new guidelines. Then again, in the fire, they have put some additional requirements for the OT. So this is the guideline I'm referring to. If you put this, it is freely available. Please read this. And same thing, you put CSSG, you get another set of guidelines. So these two would be the take home from now. If you really want to go, please read few pages from this. And in CA, if you see, go to point number 4. Window ACs and split units should be preferably not used, as their pure recirculating device becomes a source of infection. So in cluster end off, in and off, as anything happens, if you are having split ACs, this is being thrown in your face. Okay. Then size of OT. CA says if it's a minor OT, okay, 10.5 square meter plus 30% circulation space, that is for eye hospital where procedure done in local and regional anesthesia, right? But if you are using GA and sedation, then you have to go for regular OT size, which is 24.5 square meter. Okay. So more confusion for size. This is what I would say. See, when I was doing my PG, this is where I learnt my FACO, Alcon Universal 2 and Zeiss FR1. And these are very small ones if you have seen them. And now you are getting a microscope which is like this. You are getting a FACO machine which is like this. And Boyle's apparatus which was this, and it has become like this. So you have also to realize that whatever OT you have to fit in all this equipment. So be very practical about the size. When you put a chair, when you put your stool, when you put your trolley, do you have space to put all these things? And then you have space to move around, right? So if you calculate that, your OT would not come less than 12 or 14 in every dimension. So it will be like minimum 14, minimum 12, and some circular space. That's the size which you will end up, right? But OTs are made as per the building which we rent or building which we own. Okay. This is for hospitals which are not owned by yourself. So typically I'll be throwing this slide in face of my CEO when he talks finance, and this is what I would tell him. And that's why sometimes they don't like me. Okay. So if it's my own practice, here is something which I would aim for, that where we can have the best quality, what we can deliver with the limitations which we have. So this is a slide. If you look at when we're talking about equipment, this is some kind of a visualization you have. That, this is my OT, how's the flow going, how are the things going to move, what is the kind of a 3D layout, how I'm going to place the equipment, how I'm going to operate, how I'm going to expand, and you have your answer. So form follows a function. Once you have functioning of OT in your mind, then you will see all. We don't have an extra skill to evaluate a design. All of you can do, but you are looking at other factors. Try to look how it's actually going to be function. And then obviously we had a discussion on maintenance equipment and all, so I'll just skip that part. But this is how you have to look at each function of OT, and then that will be the form which follows that. So an OT, you start with a 2D design, put in your equipment and other thing, your lighting, spangles, and then you have a 3D design. And in an operation theater, again you have to look for the flow, the zoning. Where is the unclean going, where is the clean zone going, and plan accordingly. Everything is available in any book on OT design. It's on Amazon also. Pick up on, you put one OT design in Google, you get design. The way is you look at how things are moving. And this we can skip. CSSG again is one part which has to have a flow. So we are talking about instrument cleaning. You clean your instrument, you process them, dry them, pack them, you autoclave them, or you do whatever sterilization you're doing. And then comes the storage part. They also need to be stored under standard condition after that. It's not that we store them anywhere. Then your validity of sterilization process can't be confirmed and monitored. Same thing, the zoning in OT, which was again shown, we'll have all the zones, and you go from progressively clean to, unclean to clean, and that's how you clean and maintain your OT. So you can have a zoning whereby, you have all these flows mapped, where you go from CSSG to OT, patient flow, material flow, and everything. OT walls can be any material, they should be cleanable. Most of the OTs in Bangalore will have either, some kind of a modular OT or some kind of a steel or some kind of paint also will work, which is antibacterial, antifungal. It's available if you find. And door should be 2-leafed. The edges have to be coved for cleaning. You saw in that video also, the edges are covered so that you can clean everything. And lighting has to be the shadowless lighting, and there. If you are taking steel, you have to go in for stainless steel 304. 304 is a specification which is non-rust, non-corrosive, which you have to use in OT. 2 doors, sliding door, single door, modular doors, PCGI, what we call powder coated GI doors. They can be single, this one first is a sliding, they can be 2 door, they can be unequal door, lots of things, but they have to be hermetically sealed to have a positive pressure in your OT. So there should not be leakage. So they should give a hermetic seal. Floor, epoxy is one what you can use. Homogeneous vinyl sheets, you get big vinyl sheets, not the one which you get at JC Road. Those sheets can be used. Any hard marble or carbonite. Basically, you need to have a floor which is hard for the movement of equipment, stretchers and everything, and it should be cleanable with the chemicals and repairable. So scrub, again, anything which can be non-touch, foot operated, knee operated, elbow. And the scrub thing is, you have to have enough depth so that there is no splashing of water. You have scrubs which are very shallow, then everything starts splashing. Pass box, in case you need, and this is standard available. NABH guidelines, you can go for OT available, so it only stretches on, the equipment load and occupancy of 5 to 8 people. And I forgot, if you are in a teaching hospital, then you are straight away CA level 4 hospital. The standards are totally different, and it's based on the fact that you need more occupancy in the OT. More people will be in OT. Right. And these are some of the guidelines again on HVAC, which comes from ASHRAE, and ASHRAE guidelines again find a link to whatever we are seeing. So this is just last slide which I'll show. This is what a modular OT is. You have a sheet, you have a plane, like, the entire floor is yours, and the modular OT will have only 1 or 2 concrete walls. Rest all is this structure which you built. And then, they are built with everything inbuilt and everything like monitors, everything inbuilt. This come as a unit which can be done. So they are standardized unit. But if you have 4 walls, you are not building a modular OT. Right, you are just overpaying for something. AHU we saw. So these are outer unit where have you 2 filters, 3 and 5, which you blow and you can clean. HEPA filter are inside, which you don't. So this is how it is. This one goes on the rooftop, and the air is there. Ducting and insulation, aluminum, we use 24 gauge GI with insulation. And this is how the laminar flow, that planum goes up and you get a laminar flow. So the thing with laminar flow, and I think so I'll end there, is the laminar flow when you make in OT, it is in a particular area. If you shift your table, the laminar flow effect is gone. So most of the time, you find that the laminar flow is in the center of OT, but table has been offset. So if you really want to offset your table, you have to plan that from the beginning and plan your flow accordingly, right? So a good laminar flow OT will not function if we change the direction of our tables because of Vastu or because of anything else. Right? So that would be all. I hope I have not answered, but there are enough resources here which you can refer to and get your answers. Right? And this debate will not end. Probably next year also we'll have the same talk, same debate, something, because our government, unless they give a uniform guideline, we are also under pressure that, economics come. I really have to compete with others also, or I have to keep costing in a range. So that's what will be thrown at us at all the time, that, many things, does it make economic sense to us? But if it's a standard guideline, then everyone is spending that money. The baseline is raised, then it's very easy because you have to meet that in any case. Everyone has to meet that baseline.
Thank you, Dr. Gagan, for that informative, well laid out talk on OT layout with guidelines and references. Next, I call upon Mr. Shailesh Mehta to talk on Know Your Autoclave validation, commissioning of autoclave.
Basically, I'm not a doctor. I'm more into process engineering. To brief you, the crowd is small, so I think we can have a very good interactive session. Every autoclave, you get a sterilized product, right? So now, the limitation is, you have to understand what is the limitation of your autoclave. I'm sure all of you own an autoclave. Each process, all the autoclave runs at 121, 134, right? Now, how do you understand? You have set up lovely processes at home. You have a lovely autoclave at home. You have a pressure cooker. You cook rice, you cook dal, you cook meat. For rice, you give 1 whistle or 2 whistles. For dal, 3 whistles. And for meat, 5 whistles. So your processes are in place at home. What's happening in ophthalmic is you've been having an autoclave, buying a pressure cooker, but nothing, the processes are not in place. So I would appreciate you have a process of meat in ophthalmic. So your rice is cooked, dal is cooked, and meat is cooked. 95% of the clinics I've been seeing, they've been cooking meat with the process of rice and assuming meat is cooked. So how does it work? There are different kinds of autoclaves, so called as the smaller type S and type N and type B and class B, whatever you call it as, class B sterilizer. And so class N is a autoclave which has been used for more of a liquid process or for a dropped instruments. You have to set a goal. I happen to just overhear the OT planning and everything. Have you set a goal for your clean room management systems? What is the CFU counts, bare minimum you have to achieve first? So there's something called a sterility assurance level for OT. There's something called a sterility assurance for CSSD. So in this particular kind of process, whether S or N, you never achieve. So in case if you've been having any implants, whether it's orthopedic or ophthalmic or any implants, you can't put it into this process. The cross-infection rates are so high into the patient. So you have to understand the limitation of each process. I don't want to go too deep into each process. So class S is a good gravity process for solid goods, wrapped, and you can set up a process, right? Liquids, I don't think so in ophthalmic. Yeah, ophthalmic usually I see ringer lactate to be re-sterilized again. God bless you guys. Now let's assume you have a growth in ringer lactate. You have some microorganisms and you're going to kill it in autoclave. Is it more dangerous? Yes, endotoxins are not the big issue for you then. Because you're going to kill someone, he's going to spit and then go, right? This is literally going to happen. So in case if you want to monitor the endotoxin levels, the processes and everything, I think just 15 minutes is not, I usually give a talk on cleaning and sterilization is for 6 days, right? So I'm just trying to cover whatever best just to keep you guys happy with that there's a presentation. So you have an autoclave which is 5,000 rupees, you have an autoclave which is 1 crore. All are running at 121, 134. How does it work? At home, if you cook 1 potato, does it take the same time? Even for 10 potatoes the same time? Yes, it's nothing but a pressure vessel. So you giving a overkill time, 6 minutes, 10 minutes, 15 minutes, it's all stupidity. What kill you get in 2 minutes, you're going to get the same in 10 minutes. It works on pressure. So again, school days, we have learned the Boyle's law, the Charles law and everything. How do you correlate? Again, shortage of time, I can't cover that. The dilutions, the main thing at home also you give 10 whistles, 5 whistles, 6 whistles is basically to remove air. More the air you remove because air is more heavier than steam. That is a problem on the gravitational thing. So the penetrations of steam becomes a bit difficult into the process. So the more the air you remove, the deeper the penetrations you get. Your phaco tubes. If anybody is into phaco tubes reprocessing, putting into class S and N, it's ridiculous, nothing has been happening. And I see quite a few vendors selling class B to most of the ophthalmic hospitals and clinics, which doesn't work like class B sterilizer at all. Because for few bargains or few thousands or lakh, you've been compromising a huge thing on the penetrations of the lumens, which doesn't take place. So how do you validate these processes of class B? There are standard specifications of dilutions of air removal, which we can just teach you in case it's a hands-on, we can show you exactly how it works. A flash process again, which I told you about class N, this works on that. It's a wet process, no storage, limitations. I'm sure you guys are giving production date, expiry date, right? Yes. For ETO, how many days?
Depends on the packing material.
No, the backing material is the same. The bacterial barrier is the same. So ETO 6 months. Steam?
3 days.
3 days. So you have educated. So you have educated bacteria coming in ophthalmic segment. They look into the pack, educate. Oh, this pack I'm supposed to sit after 6 months. Does it work? No. If your assurance levels of the clean, so CFU calculations in case someone wants to learn, I can teach you a lovely process. Your validation is going to be the same. Because your infrastructure, your differential pressure in the OT, your humidity conditions, correlations with CFUs, how it works, we can go deep into the subject and teach you this process. Again, your resistance of the D value, I was been told that to use hydrogen peroxide in one of the presentation, God bless you guys. if you're using a hydrogen peroxide in a AHU, first thing is what is the humidity required. You have to reduce the humidity to 20%, then push in hydrogen peroxide. So that chemistry, in case if anybody wants to learn, I can just show you exactly how it works with the resistance of the bacteria. There's something called as auditors come and tell you, where is the Bowdic test? I see 90% of the ophthalmic industry having a gravity process and gives a Bowdic and NABH accredited patient Damal. NABH gold. So limitations, you might be shocked in an autoclave. Bigger the lumen, your cross-infection rates are higher. Smaller the lumen, your cross-infection rates are lower. Why? It's easy to kill in a smaller lumen, difficult to kill in a bigger lumen. So there's a calculations on HPR which we can teach you in the next presentation how it works. Yeah, please go ahead. Your CFU counts calculation works on this. I think we have done it in Narayan Netralaya, a good amount of studies since the last 10 years. Each year, the valuations on CFUs changes. Okay, so in case someone wants to learn something more on the autoclaves, it's amazing. And then set right your processes, how to evaluate. Now take for example, 0.5, you put in all 1, 2, 3, 4, 5 material in one load. The first one is passed. The fifth one is shown a growth. What do you do? At home you change the cycle or no? I would appreciate the same to be done and keep that as a standard. Then you say, no, ma, I'm not getting it. Then tell your owner of the hospital or you are the owner, get rid of non-veg, be a vegetarian, no complicated cases, stick on to your regular ophthalmic cases because you don't have the infrastructure to reprocess this. Nothing else. I think I wind it up. There's a hell lot of me to talk in case if you want me to talk on hydrogen peroxide, ethylene oxide, potencies, correlations, toxicity, OT.
Yeah.
I can give a lovely
questions,
presentation.
but I think so we can come back to you at the end of session.
I'm through with it.
Yeah. So one question I believe, and that was a discussion which you're having. Do we have some kind of a centralized external facility in Bangalore for reprocessing like we get in West?
See, the thing
are
is,
you aware of anything or you know? Because let's say if someone really wants a part of the CSSG service to be outsourced to a facility which can match up certain standards, is anything available in Bangalore?
see, the thing is the infrastructure and the correlations of transportations, ROI. Have you guys ever calculated the ROI on reprocessing that? I don't know about ophthalmic, but take for example CABG, cardiac case, TKR, knee case, ophthalmic. Which is more difficult, the ophthalmic or orthopedic? Which is more difficult to sterilize, the instruments, ophthalmic or the orthopedic?
Lumens in ophthalmics, implants in
I'm talking
orthopedics.
in the whole set of orthopedic, the whole set of ophthalmic.
Ophthalmic, I believe.
Ophthalmic is more difficult and what does the guidelines talk about? In a TKR set, you need a biological indicator,
With every kind.
but not a ophthalmic because ophthalmic is a schedule cast, right? Nobody understands the science. For that, you have to understand the Boyle's law, the Charles law, which is correlated to the kill. So I've been giving huge number of talks on this. On behalf of a country, I think we have taken a country far ahead than the Europeans and the Americans who still have to understand exactly how the processes work. And we blindly following some guidelines laid by the Europeans and Americans is stupidity because our country works on differential pressures. So where your clinic is located, in case if your clinic is located in Chennai, your protocols are different compared to the protocols in Bangalore. That has to be understood. Your sea level pressure, differential pressure is correlated to your growth of microorganisms. I can talk more on that next time. Thank you guys. Love you guys. Have a lovely day. And me being a last session, I would have bugged you guys. Thanks anyway. Thank you.
Thank you. And I'll request Dr. Savita for next talk, which is record keeping in CSSG and OT.
Good evening. At the outset, I would like to thank BOS and Dr. Ellen for the opportunity. And I would like to share a few thoughts on record keeping in CSST and OT. So, Why is record keeping important? Because it's universally record keeping is essential component and specialized area in healthcare organization, and it is required for the purpose of audits, preservation, and also for legal purpose. So the records can be either paper based or computer based. So paper based records are documents which must be in hard copy where authorization is required, and computer based records are for long term preservation. They have easy access, easy recovery, limited workspace and manpower, and it's cost effective. So, what is a CSST? As all of us know, it's a key area where there is a centralization of decontamination, assembly, sterilization, distribution, and control of sterile items used across the hospital. And the objective here is the right item is there at the right place, at the right time, in the right condition. And scope is to provide and render service and maintain quality aseptic control procedures. And here the workflow is unidirectional. There is a dirty area, semi-clean, and a clean area. So, the OT represents one of the most critical hospital units, and yes, because for patient safety and financial terms, and a good record keeping practice is very important because it reduces the rate of infection, thus ensuring patient safety. It makes everyone in the team more accountable, and in case of infection, the incriminating item can be easily traced. And records help the hospital to avoid any future implications related to sterilization, and it is more a transparent process. So, coming to documentation in CSSD and OT, these are some of the documents that has to be kept, and the documented manuals in the form of policies and procedures, some validation documents, logbook and registers, training documents, staff health checkup, vaccination status, instrument recall, and incident reports. So the manual, and in the manual, the policies and procedures of the OT, and which has an organogram, the job description of the OT staff and the responsibilities, the area layout, operational procedures, and recall procedures. All these are documented in the manual. Coming to the validation documents, there will be the installation, operational, performance qualification. These have to be maintained, and also the indicators that are used, and the daily maintenance, planned preventive maintenance, breakdown maintenance. So all these records come under validation documents. And in the installation, there will be date and operating instructions, copy of the maintenance contract. And coming to the performance, sterilization and identification, batch number, date, all these have to be there in the record. And in case of planned preventive maintenance, the date of service request, description of service performed, personnel who attended, and the signature of the person who attended to the work, all these have to be documented. And the logs and registers, the logbooks and the registers, it can be, you can, this is not a recommended this thing, but by and large this covers all the requirements. The autoclave register, sterilization check register, room temperature register, microbiological culture report, OT disinfection register, medical gases register, and medical supplies stock register. OT refrigerator temperature register, implant log file, OT consumable sheet, manifold room control record, narcotic drug register, and water quality testing. So all these, it is better if it is kept in the OT, which will be handy. And this is a video. Of the various registers, the autoclave register. This is some of the formats that we follow. The sterilization register, the temperature monitoring register, microbiological culture report, OT disinfection register. If you have various OTs, this is how it is monitored. Medical gas cylinder register, medical supply stock register, OT utilization, which we analyze at the end of every month. The register, refrigerator temperature register, checked twice a day and recorded. The implant log file, manifold room control register, narcotic drug register with the stocks. And these are the service reports. OT microbiological surveillance. This is the OT manager collecting the samples from various designated places in the OT from the microscope. From the tables. So that was about the registers that are mandatorily kept in the OT. And coming to the training documents, so this has the departmental policies based on which we can train the OT staff and the nurses, the operational procedures, validation, infection control and biomedical waste disposal, handling of hazardous chemicals and safety protocols. So based on all this, the OT staff and the nurses have to be thoroughly trained. And we also maintain adverse event register, an instrument recall. So whenever there is an infection or when we are doing the root cause analysis, we can have an instrument recall based on the RCA done, corrective action and the preventive action. Also, an incident report can be maintained, which happens in the OT. So this also has the RCA and the preventive action. This is how the recall register looks that we maintain. And also the registers that can be maintained as a soft copy are the documented manual and the SOP, the standard operating protocol, and training records. So these can be maintained in the soft copy, and the retention period, most of the time we will have a doubt as to how long it has to be kept. So not less than 2 years, and permanently that are kept are documented manual, product certificates and MSDS sheet. So to conclude, good record keeping is a legal responsibility of every healthcare organization. An ideal record keeping should be correct, complete, and it should be consistent with date and signature, and it should not be tampered. Well-defined record keeping can make it easy to understand what quality work practices have been performed on a daily basis with their quality of manpower that are associated with this work. However, unnecessary collection of data and record keeping can be quite laborious and expensive. With this, I thank the audience, and also I thank Dr. Gagan for moderating. Thank you.
Thank you, madam. Any questions from audience? Everyone can ask one question. We feel happy. I think so. Let us have last talk, and if there's any discussion you want to have after that, any questions, we can turn off the video and answer you point blank. Okay. So I would like to invite Dr. Haripriya. She's from representing Jiva Mitra, and it says Jiva Mitra. Sorry, Jiva Raksha, and she's going to talk about emergency care in our. Madam, sorry, I don't have. If you'd like to introduce yourself.
Yes, sure. A warm good evening to all of you. So I'm Dr. Haripriya. I'm an anesthesiologist by profession and presently the program director of Jiva Raksha Trust. So Jiva Raksha Trust is a special purpose vehicle by Rajiv Gandhi University of Health Sciences to train people in emergency care. It's for doctors, nurses and all common public to be well equipped when there is an emergency situation to handle. So to start with my topic for today, that is emergency care in OT. So what, when and how. We are all well aware that, emergency when it happens in OT, it is very stressful for all of us to handle it. So why it is important? Primarily patient safety, outcome is important, team preparedness is necessary, and it's obviously there is a legal and ethical obligation related to it, and it builds the trust in patients as well as their attenders, also our colleagues when we handle emergencies well in our operation theatres. So as sir has already mentioned, there's operational guidelines for OT complex. So this gives a holistic approach as to how we are supposed to have a OT as well as manage the OT in toto. So in the same document, I think we have all seen a list of equipments which are absolutely necessary for OT, but most places probably would have it when the OT is started initially, but over time a lot of things goes missing and they are not maintained well. What I recommend from all of the people practicing in OT or doing surgeries is emergencies and drugs trolley is something which we have to constantly keep updated, because any emergency will not tell us when it is coming. So if the trolley is not up to date, then we cannot handle emergency at all, especially the drugs which are expired and they don't work actually after expiry. So how do we actually prepare ourselves for any emergency? It starts with pre-operative preparation. From the time we have patient in front of us, to have a good medical history, to know their allergies or any other existing condition. Like many people, especially for ophthalmologists, they hide a lot of things from us. Heart conditions or even diabetes and hypertensions are also hidden, because they feel that if we tell that, they will prolong their surgery and they don't usually share it, but it is.
What happens is when they get cancer 2 times in different hospitals, the 3rd time they are wise enough not to tell anything.
And those are the patients who go into emergency. So we are supposed to be very, very careful when we take in patients. Also, to have emergency protocols displayed and practiced in all the OT blocks, and it should include all the people handling emergencies, including the housekeeping staffs. So today, I would focus on few of the emergencies which are, I cannot say they are common, but they are the most, expected emergencies and difficult to handle emergencies. So a list of equipments and medications which are necessary, which is there in the guidelines, so I'm not going deep into it. So coming to specific emergencies, what do we do when there is an acute myocardial infarction? So we all know MI is difficult to handle. MI is something which we should focus immediately, but what do we actually do? So here in my presentation, because it's the last one and all of us have short span of attention, I'm going only into how we are going to handle it, because we all know what are the signs, symptoms and other things. So how do we handle? First thing is, if it's a surgery which can be done at a later stage, pause the surgery and you first take care of the patient, that is shift them to ICU immediately with oxygen throughout the transit from the OT to ICU. Sedate the patient if possible, because the more they are anxious, the more they become prone for complete cardiac arrest. Sublingual sorbitrate, if it's available in the OT, and if there are T inversions or classical ST elevations, please give them sublingual tablet. And if the BP is low, we can start them on dopamine. And the the vital signs have to be monitored regularly throughout the transit of the patient till ICU, till we feel that they're right now in a safe hand. So if MI is not handled adequately, or if it's a massive MI, it will go into cardiac arrest. So now, how do we actually know that it is a cardiac arrest? 3 signs, that is the patient becomes unconscious, there is no pulse and no breathing. What is the first step we should do here is effective chest compressions, and if there is a defibrillator next to us, early defibrillation. So first step is chest compression. So all the OT staff have to be trained in CPR. So the protocol we follow here is CAB, that is circulation, airway, breathing, unless all the other emergencies which are ABC. So continuous uninterrupted chest compressions is what is being practiced these days. 30:2 was there initially, but now the whole world, including WHO, is shifting towards continuous and uninterrupted chest compressions, early defibrillation, and adrenaline 1 mg every 2 cycles of CPR. So airway, we have to ensure that the airway is open. So how do we do it? Head extension, that is head tilt, jaw thrust if necessary, and if there is, we have to put some airway adjuncts into the patient, that is oropharyngeal airway, and intubation can be delayed, and it is done only if the patient does not revive even after effective CPR. Breathing, give them 100% oxygen. Ventilations is at 10 to 12 per minute. So what we say is, between the chest compressions, count, one person will be giving chest compression and the other one is at the head end giving ventilations. So we have to count 1001, 1002, 1003, 1004, 1005 breath. So that is how now we are supposed to give ventilation, not 30:2. So that has to go synchronously with the person giving CPR as well as the one giving ventilations. So here also the compressions are not being interrupted at any point of time. So when is it called a high performance CPR? First and foremost, we have to keep the patient on a firm flat surface. So most of our OT tables are not firm. So if there is a cardiac arrest, please bring the patient down to the floor and then only start CPR. Only then the compressions are called effective, because the foam in the bed itself will not give us adequate pressure. Then if you see the position of the person doing compression there, the hand is directly on the chest of the patient, that is perpendicular to the chest of the patient, the back is straight and he is putting complete pressure on the chest. His whole weight is on the patient. So that is how the position of the person doing CPR should be. And the elbows should be interlocked. Without interlocking the elbows, the pressure is not adequate and we get very tired soon. And the compression should be for a continuous 2 minutes, 1/3 the height of the chest wall, which is 5 centimeter or 2 inches is what we say. But if it's a hefty patient, 1/3 the chest wall should be compressed. And adequate recoil is very important. So that pumping effect, the video is placed there because without complete recoil, the chest compression is not effective. And the point is repeated, 2 minutes continuous, and after every 2 minutes, we are supposed to reassess the patient by feeling for the carotid pulse. So feel for the carotid pulse for 6 seconds and multiply it by 10 if you get pulse, or else restart your CPR. So what if it happens in a child? So we all probably have seen how adult CPR should be done. But for a child, the process is a little different. As soon as the heart rate is less than 60, it is a cardiac arrest in child. So we should not wait till complete arrest is present in the child. That is complete stoppage of the heart. So the moment it is less than 60, we have to start chest compressions. The rate is 120 per minute. And there are two techniques which are followed. That is 2 thumb or encircled hand 2 thumb technique and 2 finger technique. Both are good enough for the baby. And this was about early chest compression. So coming to early defibrillation, so we have 2 types of defibrillators. One is automated external defibrillator, one is manual defibrillator. The first one is manual, which is there in all the OTs, but ensuring it is charged is very important. So the manual defibrillator should be charged and ready for giving shock. Most places they are not charged, so please ensure that it is charged. And if we are using a biphasic fibrillator, then it is 150 joules. Monophasic is 200 to 360. That function is already there in the ventilator, so you can adjust accordingly. And for babies, it is 2 joules per kg. And we have to make sure we say I clear, you clear, and all clear before shocking the patient. Otherwise, we ourselves are going to get shocked. And coming to A, B, C, and D of cardiac arrest, airway should be opened with head tilt and chin lift, and any airway adjuncts like OPA or NPA should be used. Breathing is always through AMBU, again 1001, 1002, 1003, 1004, 1005, and breath. And the drugs are adrenaline, the most important one, 1 mg immediately, and it should be flushed with saline so that it reaches the bloodstream, and repeated after every 2 cycles. So coming to next important emergency which might occur is hypoglycemia. So hypoglycemia is nothing but a blood sugar of less than 60. So what do? We have to replace sugar. So how do we replace sugar? 25% dextrose, 2 ampules given intravenously, and the IV drip for a continuous maintenance should be continued. And even if the blood sugar after dextrose is not improving, we have to give them glucagon. Seizures is one more thing which might be a part of emergencies in OT. So how do we manage seizure? we are supposed to wait for the seizure to stop. No active interventions right away. It might just be breakthrough seizures because most patients skip their medications on the day of OT. Even though we would have told them that all your regular medication should be taken, they generally skip it. So it might be breakthrough seizures, so we need not do anything. But even after 5 minutes, if the seizure continues, we have to start them on anticonvulsants. And another one is pulmonary edema, which is very common with any person with congestive heart failure or any heart conditions. So we have to first and foremost make them sit up straight and give them high flow of oxygen and Lasix, that is 40 to 160 milligram, and maintain the BP with nitroglycerin. So I only have one more slide with emergencies. So perioperative anaphylaxis is one more important thing. So how do we manage it? First of all, withdraw the drug which is actually harming the patient. That is, anaphylaxis inducing drug should be withdrawn. 100% oxygen. Then again administration of adrenaline. Here adrenaline is given IM. So IM 0.5 mg should be given intramuscularly, and put the patient in Trendelenburg position and then give adequate fluid therapy. And if there's bronchospasm and if you can hear the wheezes, then salbutamol or albuterol should be given. But to actually do all these things, we need a very good team of good team in the OT. So everybody should know their roles and responsibilities, and to handle any emergency in OT, we at least need 4 to 5 people. So 1 or 2 people cannot handle any emergencies. So the protocol should be displayed everywhere. Communication coordination should be at the foremost. And how does all this happen is only through training and simulation. So with adequate training, everyone will know how to respond immediately to emergencies, and with simulation, they will know when to do what, and it should be a continuous process. So thank you so much. So I come from an organization which trains everybody in emergency skills, so feel free to contact me anytime. Thank you so much.
It's okay. So that's end of session. Anyone have any question, comments? Recording can be stopped. We are done with it. Hi, Tupan. Stop. End of the day. Anything? Anyone wants to comment? Wants to add also? Anything important which we have missed, which you feel you want to highlight?
First thing is, in ophthalmic, hydrogen peroxide, so-called plasma. There's nothing called as plasma sterilization. It's nothing but vaporized hydrogen peroxide. And it's got its limitations. So using it for lumens, out of question. Nothing happens. Okay? Nothing happens. Again, the kill bit